talk a little bit about the clinical pathologic findings in animals with renal disease. We went through the CBC already. And as far as the biochem, so I mentioned the 3 cell lines that we looked at on a CBC, right? And you guys know it. And there's a reason why renal disease patients may have anemia. There's a reason why renal disease patients may be hemoconcentrated, so have polycythemia, especially if you are dehydrated and have acute kidney injury. By the way, acute kidney injury and acute renal failure are synonyms. The new terminology is more acute kidney injury instead of failure. But it's the same thing. All right, so in biochemistry, what are the things that we look for as far as when we open a chemistry panel? Things are separated. As far as the anatomy of a chemistry panel would be renal enzymes, which are what? BUN, creatine. Then the electrolytes associated with GFR, which is phosphorus and calcium, right? And then maybe you can throw in there a bicarb level or a total CO2. Not every chemistry has it, but you can see sometimes a CO2 level. That's bicarb, essentially. So it should be part of the renal portion of the chemistry. Then you tie that in with a specific gravity, right? Even though it's not a biochem panel, it's still a urinary panel. And that would make up your renal, quote unquote, side of the equation. Then you get hepatic enzymes, right? So ALT, ALP, and then you get your biliary tract, which would be total bilirubin. And am I missing something there? Total bilirubin. So ALT, ALP, total bili. And then the functional aspect of the liver, which would be glucose, right? Albumin is kind of like, part of it is the liver, right, because you have to make it, but part of it is the kidney, because you might lose it. So albumin is kind of in the middle. And then come, I guess the rest would be more random things that I can categorize liver versus kidney, like globulins. And so if you add globulins and you add albumin, you get totals of proteins. That's where it comes from. And that's pretty much our biochem panel. As far as amylase and lipase, what are they concerned with, amylase and lipase? Pancreas, but they're very insensitive. So we pretty much don't use them anymore. And as it says here, a patient with azotemia, whether it be pre-renal or post, could have elevations in amylase and lipase just because those enzymes are excreted by the kidney. They have nothing to do with if you have excessive amounts because the pancreas is swollen, i.e. has pancreatitis. No, it's just that if you have azotemia, you don't excrete those enzymes as much. So don't be fooled by an amylase and lipase in a patient that's azotemic. All right, hyperphosphatemia, I don't have to talk about that. That makes sense, right? Decreased GFR will lead to high phosphorus. Calcium levels may be low, normal, or high, but most of the time they go high, right? There are cases where it could be low, depending on the underlying etiology. Like, for example, with ethylene glycol, you can get precipitation of calcium and phosphorus, and your calcium will go low. But most of the time, the calcium will increase because your GFR drops, and calcium has to be excreted by the kidneys. Bicarbonate, pretty self-explanatory. Amylase lipase, we talked about that. Cholesterol, I'm not sure I see hypercholesterolemia that much in a patient with kidney disease. And albumin, again, associated with glomerular disease, leakage basically of albumin right there at the filter. Urinalysis. So we want as much as possible to get a sample by cystus and decis. That's pretty much saying that you're going to use a needle, prep the area sterilely, and then you're going to get the urine sterilely. So that avoids any contamination from the lower urinary tract. So we talked about the specific gravity. I don't smell my urine. I don't, like point number 3, urine odor. But I guess it is true that patients that have a UTI, that urine smells more like ammonia because they have urease, that enzyme urease in the bacteria converts urea to carbon dioxide and ammonia smells very specifically, but I don't go by that, right? I culture it. pH, it can be all over the place depending on the diet of the animal, and depending on the time of day, right? It's cyclical, your pH is not constant. So at the end of the day, if you have a high pH, then you could maybe assume that you could have what? A bacteria in the urine that produces alkaline urine. So most urease producing bacteria also create alkalotic urine. But again, you have to culture that. I wouldn't just go by the pH. Urine biochemistry. Urine biochemistry is pretty important. It's really hard to diagnose renal causes of azotemia without urine. So whenever you see a BUN and creatinine elevation, your first instinct should be, where's my urine, right? Because you could have pre-renal causes, and you don't know until you check out the urine. So what are abnormalities associated with the urine when we have a patient with renal azotemia? Then you could have some protein, right? You could have some glucose. How can you tell if an animal is diabetic or if it's just glucose from tubular damage and not being able to reabsorb the glucose appropriately?
White serum.
Yeah, so you'd be hyperglycemic too. So a hyperglycemic animal with glucosuria is more apt to be diabetic. However, I've seen stressed cats that have both, and then you put them on food therapy overnight, and then you check them the next day, and they're not hyperglycemic, and they don't have glucose in their urine. So if you really get stressed out, like a cat does, you could spill over glucose from your blood into your urine temporarily and not be diabetic. So in cats, that rule is not as cut and dry. You should recheck the next day when they're feeling a little bit better. In dogs, it's pretty confirmatory of diabetes. Ketones, same thing, if you see a ketone positive stick, urine stick, you have to trace it back and say, is the animal diabetic, right? If it's just ketones, it's probably that the test cross-reacted with some other compound in the urine. And because they're not very specific, these are just little strips. They can cross-react with pretty much anything. And so you have to be alert for false positives. So I have a hard time believing a ketone stick that's positive in my animal is not diabetic. Make sense? Bilirubin, same thing. If I don't have a high bilirubin in the blood and I see bilirubin in the urine, it probably cross-reacted with some other osmol that pretty much carries the same pigment and sticks to that area of the urinary strip. Blood is funny. I mean, if you do a system and you don't know what you're doing, you're probably going to be hitting a lot of vessels going in. So you're going to get like a little CBC plus UA on those samples. So you have to be careful. They saw white cells, they saw red cells in the urine. Yeah, probably you went through a vessel, right, as you got the sample. So you have to kind of differentiate that. But ideally, the best advice would be to get clean sticks, as they said, and not get them contaminated. Now, if you do have a lot of blood, like it comes out pretty bloody looking, you have to spin it down to make sure it's not myoglobin or hemoglobin, right? So if you spin down a sample of urine and it's sediments, then probably those are red cells, and it's red blood cell in the urine, or blood loss in the urine. But if it stays kind of turbulent and reddish, then it's probably hemoglobin or myoglobin, one or the other. So a patient with IMHA, you do a urinalysis and they probably will have a urine that looks bloody. What do you think it is? Hemoglobin. And the last one, leukocyte esterase reaction, I don't look at that ever. You pretty much should have a sediment check, right, by the pathologist, not just a strip that says that leukocytes are there. this is the typical strip. You see leukocytes on the top, we ignore it. Nitrate, ignore it. Urobilinogen, and depending on the bilirubin of the animal. Protein, I pay attention to that. What would be more significant? A high protein in my urine, let's say it's protein 2,000 or more, very high. Would I be more worried if the specific gravity is low or if the specific gravity is high and I have a high protein? High? Why is that? Because you're releasing in the urine. I love it. It would be low, it would be the opposite. Because you're releasing a lot of protein despite the fact that you don't have a concentrated urine. It's almost like the protein stands out a lot more, right? If your urine is already very concentrated, full of all of it, plus sodium, plus chloride, plus whatever, and your protein is also high, it's probably that everything is concentrated, right? Everything, including the proteins. Because you have very little water in the urine. Make sense? So specific gravity of 1055 or above, I pretty much don't pay attention to anything positive. Because that urine is very concentrated, especially in a cat, right? Now, if the specific gravity is 1010, 1012, and my proteins are high, I'm like, this animal is probably on renal failure, and the glomeruli is messed up. That makes sense? So always look at the protein in the context of specific gravity. pH, not a lot to say there. Blood, be careful with your cystocentesis. Specific gravity, much better to use the refractometer than to use this strip. So refractometer was, let me see if I can find it. That's the refractometer. Ketones, again, it can cross-react just like bilirubin, so be careful. And glucose, we talked about that too. All right, now urine sediment. This is not easy. I'm not great at doing urine sediment, but basically I say, is it active or not active? You know, I don't look at specifically, this is a hyaline cast. To me, it all looks the same, but it's because I don't practice it, right? So there's this chart is trying to tell you that there's a lot of stuff that could be found normally in normal urine in low levels, right? And there's other crystals that will be more specific for acidic urine and alkaline urine. So basically pH matters when you're trying to assess a sediment. So don't think that urine is devoid of anything. No, it has some cells, it has some crystals, but they're a very low level. And so when you get a urinalysis back and they do sediment analysis, they will put white cells 0 to 3 per high power field. Normal. Not 0, but 0 to 3. Even if you get a clean stick and you didn't hit a vessel. What you shouldn't have is bacteria, right? At all, if you did a cystocentesis. So what if you get a urinalysis and they say bacteria? I get this like 75% of the time when I submit a cysto. Suspect presence of bacteria. So what do you think that means? That, what's that? No, I usually change the needle. So that's a good point. When you do a cysto, right, even if though I prep the skin, I change the needle before I put it on the tube. Because that needle will, in theory, go through skin that might have some contamination. But that's not the reason. It's because they're doing sediment analysis with a machine. And the machine may look at stuff like this and think it's bacteria. So at the end, the only way to tell if you have bacteria in the urine and an infection would be to culture it. That's it. You cannot use a UA to say that the animal has a UTI or pyelonephritis. Is that pretty clear? So every animal with azotemia and an active sediment should get a culture. Okay? The problem is that those results are going to come back in 3 days. And so in the meantime, you need to do something about it.
So the first thing we do when we suspect the UTI is a urinalysis.
Mm-hmm.
So is that useless then?
No, it's a screening test, but you can have a very active sediment and have no growth in a culture, or you can have a very quiet UA, like very normal, culture it and then grow something. There's a screening test more than anything, and I've seen both. Now, if it looks like it's a very active sediment, the patient has polyuria or dysuria, hematuria, then, clinical science and history also, you have to tie them up. Then the chances are higher that that dog will get has an infection, right? But in general, you can't tell from a UA necessarily to have an infection, unless it's super obvious. Because the tendency is for the urine to get more dilute with renal failure or with infection. And that makes it harder for the pathologist to see any evidence of infection or any problem, okay? So that's why you have to enrich it, grow it, culture it. All right. Abdominal x-rays. These are pretty cool x-rays that outline. Obviously there's contrast here. This is a pyelogram, right? So you go with this, you inject this IV, and it will go through the afferent arteriole and make it to the glomeruli, and eventually makes it down into the renal pelvis, the contrast agent, and down into the bladder. But essentially you see like usually the left kidney is a little bit, this is an animal on its back, okay? This would be left. So left is usually more caudal than the right, okay? The author here tells you some cool reference ranges. I don't use this too much, but I should. So you use L2 as a reference. This would be T13, you see the ribs here? L1, L2. So if we grab this length of L2, let's see if I read this correct, then the dog, and you use something to measure it, then that kidney should be 2.5 to 3.5 times that kidney. With enough x-rays, you start looking at them and going like, that looks big. It needs an ultrasound. But when you're starting, or for now, you should know these reference ranges. And if anyone has any question on how to use the L2, let me know. Pretty much like the vertebral heart score, right? I still don't get that. Because you look at many hearts and you go, that looks a little rounded, that looks big. So I wasn't trained with numbers, and if I have a question, I put an ultrasound probe. But I can see the value into doing it when you're beginning to look at a lot of x-rays, right? To train yourself to be more objective. In other words, do what I say, not what I do. Just for the x-rays. Ultrasound. The bottom line with ultrasound is you can have a normal looking kidney and still have renal disease. Okay? So some renal diseases are just like homogeneous, they leave everything intact, but you do a biopsy and you catch it. But most of the time, acute renal failure will give you plump kidneys and they look swollen. And if you look at the ultrasound, you see a little rim of fluid around the capsule, right? And most of the time with chronic renal failure, you get the opposite, small, shrunken kidneys. And you have a lack of definition when you look at them. It doesn't look homogeneous from the cortex to the medulla. They look like scar tissue, basically, in general. But again, you can have a normal looking kidney on ultrasound and still have disease. Renal biopsy, I haven't done one in a while. They're not very hard to do. The problem is that renal failure, unfortunately, all roads will lead to one common pathway. So you can have failure from ethylene glycol, you can have failure from leptospirosis, from chronic renal failure. At the end, the pathologist will tell you there's scar tissue, there's inflammation, but they don't tell you any etiology, right? So it's like you would only do a biopsy if the owner wants a prognosis of how many remaining nephrons are there that are healthy. Not to know what the heck is happening, how to treat it, a biopsy won't tell you. Almost like liver failure. By the time your liver fails, is it could fail for many different reasons, and all roads will lead to the same histopathdiagnosis, unfortunately. With the liver, it's a little bit better because you can quantify copper and do more things. With the kidneys, like, so big things are basement membrane, right, of the tubules. If it's intact, that's a good thing. If you have more than 25% nephrons left, that's a good thing, right? We talked about this. But other than that, I don't think a biopsy offers that much more, and there's a really high increase chance of bleeding when you do it. This is not benign. So we don't do it often. All right, any questions on lecture 2? Now we're going into the fun stuff, acute renal failure. Has anyone managed or helped manage an acute renal failure patient? All right, talk to me about it, man. Uh-huh.
And from the get-go, it had to make it so we managed that one with intense fluid therapy and then antibiotics, basically.
How long was he treated for?
He got treated, I think, for 4 days. He was there for like 4 or 5 days.
Was he doing UT or? So they did everything like that?
Yeah.
Did they put a central line?
He didn't get a central line. He got a urinary catheter for sure. He was in isolation. And then they started treating him with unison